From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
And hi, everyone, and welcome to Season 6, Episode 237 of the Crisis Jam. I'm Dr. Brian Sims, Senior Medical Advisor with the National Association of State Mental Health Program Directors, and I am thrilled to be a part of this particular Crisis Jam. It's going to be a wonderful jam. Just get yourselves ready for it, because today we're going to be featuring a fireside chat going beyond the checklist and engaging with risk with Dr. Jack Rozel, and it's going to be moderated by our own Dr. Chuck Browning. So looking forward to this coming up very soon. If we move on, I just want to remind you that during our times that we've had backstage pass where we've asked people about a sound check. So today's sound check brings you to the Crisis Jam this week. And this is to encourage you not only to respond, but respond in the chat box, kind of get you used to using it, but also gives you an idea about how others are feeling and what at this point brings you to the Crisis Jam this week. This is great. Now, the other thing I wanted to share with you is that for years we have been working with the talk.crisisnow.com site. We are now moving to crisisjam.com. Much simpler navigation site when you take a look at it, because not only is crisisjam.com available, but now also in that is going to be crisisjam.shop, so that you're able to do some actual shopping through the site. And we're going to post all of that into the chat box for all of you. But this new site is now shaping the future. You're going to see that it offers all sorts of informational status where you can talk about the Zoom access to it, our YouTubes, watching the live streams, and even in the newsletter by staying in the know. You'll also be able to see some things that have occurred in previous jams, where we had the huge Battle of the Bill one that was very, very popular, including our lead stories and crisis news. So it kind of gives us a lot of wonderful things to work with in that site. So we encourage you to go into the site, and if you haven't already registered, please do so. Also reminding you about our YouTube uplinks that you're free and able to go into. So at any point in time, please access that. And our next slide, we're going to go into our breaking news. And our breaking news for today has to do with the ongoing Crisis Con that is going on in Indianapolis. It started back on the 28th, and I believe it's in its last day of operation. And it's such a phenomenal thing that you can see is represented by a number of noteworthy individuals who've been in the crisis field for quite a long time. But we have as our person today, the wonderful Dr. Chuck Browning. And Chuck, I'm going to ask you to come on out if you would, because I really would like to just kind of talk to you a little bit. I understand that you are actually at the Crisis Con as we speak. Is that correct?
I am, Dr. Sims. Can you hear me and see me on here?
I can hear you, but I can't see you just yet. But I hear the wonderful voice, sir. Well, I was just going to kind of touch bases while we get the video portion taken care of. There you are. Wonderful. Great to see you, Doc.
Thanks. So yeah, I'm playing hooky right now from the last session of Crisis Con. It's to be up in the hotel room to be ready for the Crisis Jam. So I think that's a worthwhile reason and excuse. But the city of Indianapolis has been beautiful and a great host for us. The event, I think, is the largest one yet, over 1,000 people. So it's most breakout rooms, amazing cast of plenary speakers. Here is the opening keynote with our own beloved Margie, Dr. Margie Balfour, doing a speech. I think there's a little video content that can be shared.
Well, NENA, who's the National Emergency Number Association, so that's their professional organization, this year put out standards for 911, 988 interoperability.
So that's an example. You can see the size of the main stage where the plenary speakers and keynote speakers performed theirs. But when it went into breakout sessions, there was so much content, and this is one of those conferences that's been able to be present and available for frontline staff who are doing the work. And so being able to interact with all those folks who are hungry for knowledge. There was a increased presence I felt of talk really focused on leadership and engagement and well-being of the workforce was a strong emphasis and really high attendance in those. I thought there was an increased emphasis on substance use in the crisis continuum and a lot more content about mobile teams. So you could pretty much get your fill of almost anything crisis related you wanted to discuss. I mean, there were folks with federal updates and things from SAMHSA and Vibrant as well. But be really engaging event, very fun to attend, very fun to see the energy of the people who are doing this work day by day coming in and getting nourishment of knowledge throughout these past several days.
And Chuck, I'm looking at a slide now that's talking about the worker well-being and resilience. Did you want to comment or anything on that?
Some of those were the most well attended. Even sometimes, the app kind of tracks the number of people that are planning to go to particular talks, and they even had to shift some of those talks out of the breakout rooms into the larger main stage to be able to house that. And so there's seems like a real hunger for that workforce knowledge and how to be able to support resilience and recruiting workforce solutions was a big focus, and the leadership talks that went into those pieces were highly attended.
Wow, but sounds like a phenomenal conference, and just thank you for giving us that kind of overview. I noticed in the chat box someone had put in a comment that this was called the Crisis State of the Union meeting, so it sounds like a wonderful meeting. But
yeah, Sabrina's been here for the past several days. You ought to pop her on here and get her viewpoint of she was a speaker, a presenter, but has been attending as well.
Got my 988 shirt on.
Yay, Sabrina.
Well, thank you, Sabrina, for that wonderful comment, because that seems to kind of sum up everything in here. So Dr. Chuck, thank you so much. Appreciate it. And Sabrina, thank you. Now see you, and wonderful to see you again as well. All righty, we're going to move now to our hot seat. And this is now in the Crisis Jam where we're looking at getting some swag. If you may recall from previous Crisis Jams, we were giving away t-shirts to those who would volunteer to be in the hot seat per se. We're now doing it just a little bit different. We're still going back to now offering the t-shirts through the Crisis Jam shop that we spoke about a little earlier. But we're going to do it in kind of a team approach. So I want to introduce to you a couple of our team members that are going to be going on this Crisis Jam swag. Our first is our own Chief of Staff of the National Association of State Mental Health Program Directors, Megan Hout, who you all know from multiple times hosting the Jam. She is going to be one. And also we're going to have Andrea Corley, and she is going to be joining us as well. So you guys can tag team up on this. We're going to start off with the regular hot seat Q&A, where we're going to just give you guys a question. And you can do it like the Who Wants to Be a Millionaire format. You can choose to either respond to it, or we can ask the audience, but we'll make it work out for you guys. Okay, so if everyone's ready, our Crisis Jam swag question. In 2012, which U.S. federal agency designated the Columbia Suicide Severity Rating Scale, or otherwise known as the CSSRS, as the gold standard for suicide assessment? The choices that you have available are A, National Institute of Health, B, Center for Disease Control and Prevention, C, Food and Drug Administration, or D, HHS, that's SAMHSA. We're asking all those in the audience if you will respond to the poll so that they have that information available for them. But I'm going to start with you, Megan. What's your thoughts on this?
You know, to me, it would either be HHS, SAMHSA, or NIH. I don't think it's FDA. It's more of a Food and Drug Administration, doesn't deal, to my knowledge, as closely with suicide prevention. So, but Andrea, what are your thoughts?
Well, before we even go to Andrea, I just want to give you guys a little bit of something to add to it. In our run of show, we put this question out, and all of the experts in there stumped them all. So just giving you a heads up on that, if that helps any at all. But Andrea, please go ahead.
Okay.
So I also do not think it's C, the Food and Drug Administration. So I also am leaning towards the NIH or the SAMHSA HHS answer.
Okay.
Before it ever came up, the first thing I thought of was NIH. But I work closely with HHS and SAMHSA. Wouldn't surprise me if it was CDC, but I think, wow. I'm going to go for NIH. I don't know, Andrea, what do you think?
I think we should go for NIH as well.
All right. All right. We're in this together.
Let's see how the audience came out on this. The audience seemed to be heavily favoring HHS and SAMHSA.
Oh, yeah, that might be
So
it. I
knowing
mean,
all that information, as I said, it was a tough one that stumped everybody. Let's go to the answer. And the answer is, it was the Food and Drug Administration.
Wow.
you're kidding.
In the early 2000s, the FDA was wrestling with a storm with antidepressant trials in youth showing troubling signs of increased suicidal thinking. So they needed a common yardstick, and what they did was they looked around and chose their own. Instead of going through NIH or CDC or SAMHSA or HHS, they went and found their own tool, which was the CSSRC. So they have chosen the Food and Drug Administration were the ones responsible. So no big worry. It stumped everybody. In the same token, you guys are one t-shirt or other applique available right now. So I'm going to move right now over into the over and under. So we put you through the first part. Let's move to the over and under now.
I never would have guessed that answer. Never, never. So, yeah.
The experts as well. So we're good on that.
All
So
right.
let's take a look at the over and under quickly. In this one, we're going to be asking about percentages and would like to get a response first from Andrea. And so, Andrea, we're going to pose this to you, and you can give us a number, and then we'll go to Megan, and Megan, you can tell us whether or not it's over or under her amount. So, non-disclosure of suicidal ideations presents a challenge to assessing suicide risk. Nearly 7,000 from 12 countries with a lifetime history of suicidal ideations were asked, have you ever denied or concealed thinking about suicide from a doctor or clinician? We're asking the question, what percentage said yes in the US? So we're not talking global, US. So having that information, Andrea, what would be the number you would say? What percentage do you think from the US who would have said that they had thoughts or were
Gonna say 75%.
75%. Okay, then Megan, we'll go to you. Do you think that that number is above 75 or below 75?
I think that's a great answer. Wow. That's a tough one. That could go either way. I'm just gonna say under. I think it's over, but I'm going to say under.
Okay. Is that your final answer?
Under. All right.
So you're saying there's been a few that are saying that it's over. So we're going to go with that, but the actual number is 48%.
Oh, wow. Okay.
And it really kind of shows us, again, the high percentage, because it's still a pretty high number when you consider overall. But absolutely wonderful, guys. So thank you both for attending. The voucher is on its way. You'll be able to get the t-shirts.
Thanks, Andrea.
And we thank you all, and thank you, audience, for putting your information in on this. So we are now ready to move to our lead story. And as mentioned earlier, we are going to do another fireside chat. So at this time, I'm going to call back my friend, Dr. Chuck Browning, and he is going to lead us in this fireside chat on Beyond the Checklist, Engaging with Risk with Dr. Jack Rozel. So Dr. Chuck, if you will take it from here, sir.
Great. And I'm assuming, Dr. There you are, Jack. Hey.
Yeah. Hello.
So we do need a little fireside. I'm in the hotel room, so I'm trying to imagine the rumbling fire in the background as we sit down and have this chat. It's such a pleasure to be here, and I'm really honored to be able to be here with my friend and talk a little bit about risk assessment violence. We chose this title, Beyond the Checklist, Engaging with Risk, intentionally. It was all designed to be able to help talk about that when we think about risk of harm, whether it's to self or others, often in our systems, we really lean heavily sometimes on tools, structured tools, checklists, check boxes, and documentation, and a lot of talk about liability. And so we wanted to talk about what are the thoughts on that? What are we getting right? What are we getting wrong with that? And especially to add this focus to harm to others, which you're just such an expert on, and sharing your knowledge and work on that. So Jack, I know you spent your career at this intersection of assessment, violence risk, and clinical practice of engaging people. So I kind of want to start there. Where do you see our world and thinking about harm to self and harm to others as we look at trying to assess risk and deal with that versus maybe what's needed?
Yeah, right. So I struggle with this, right? And I always think, I've got to use my DBT skills. I've got to, embrace both ends of this apparently contradictory thing, because as a medical director of a couple crisis centers, I really want to know that my team is consistently clearing some basic hurdles, right? Just like we have to do for 988. Like, are we asking the right questions in the right way on a consistent basis? And I think the lead in about the Columbia suicide rating scale was just sort of perfect. I would sort of say, from a suicide risk perspective, the Columbia is terrible, but it's also the best thing we have in the category. And we don't have anything nearly as good as that for violence, right? So I want to make sure we're doing something basic, something good. And also we know, right? We know that's what the question was, how many people are saying no. The false positive and false negative rate is extraordinarily high, especially in emergency and acute settings for tools like that. And at the same time, we have the pressure from these outside organizations that says, thou shalt use these basic tools. And to some degree we should. And also, I don't think anyone ever wraps up a phone call with one of our staff members or a mobile visit with someone on our mobile team and says, well, they're kind of cold and distant. And they didn't really seem to get me or my family. But boy, they sure did nail that checklist, right? That's not the experience I think any of us want to say, oh, yeah, this is what we're delivering to our community for this very finite resources that we get. And also, there's some stuff that we got to be covering, and life safety issues. We've got to be thoughtful and intelligent about how we do that.
Yeah, that's such a key point. Can you talk to us about, I know we had a robust listserv discussion on the American Association of Emergency Psychiatry listserv about predicting risk versus working and engagement and conversational collaborative safety planning. Can you talk a little bit about the balance of where you see those things and how we discussed it in the listserv? Because I think it's valuable for the community here.
And again, it's like this dialectic, because we've got to have both. And I remember early in my training, I was with a child and adolescent bipolar clinic, and we're supposed to do these case ads. And if you know what the case ads is, it's this really long, a few 100-page questionnaire about symptoms that you ask, children and adolescents and their families. And folks at risk of over disclosure, I'm not really a paperwork spreadsheety kind of guy here, right? I'm put me in the room with the person, let me talk with them, let me hear their story, let me try and understand what's going on. And the feedback I got from my mentor, Boris Biermer, that I still remember, says, go in there, do a really good interview, and come back and fill out the paperwork later on, right? And what we've seen is in the decade, and it's now been almost a decade since the Joint Commission came out and said, you've got to use standardized screening, standardized brief evidence-based screening, right? What's the standard? The evidence is not what they said. None of it makes anything briefer, right? But the data, the science has really shifted, and we've got to get back to those good clinical assessments by well-trained, well-resourced staff who have the time and the bandwidth to do the work right. Me going into my PCP's office with the medical assistant, not even facing me, filling out something in the electronic chart, asking me the PHQ-9 screening questions or the Columbia, like it's not a great experience. It isn't going to get you real data, and also it takes time, it takes investment to make sure that our staff have the time to do this right with every call, knowing that every call we get, every visit we make, it's something different. So
Yeah, that's when we talk. I mean, the first over under question that we just went through ties into the next thing that I want to talk to you about, and especially lean into risk of harm to others, but also to self. We were talking about suicide risk in that over under that, and 48% of Americans totaled in this were not feeling safe about being able to talk about their suicidal ideation because of fear of coercion. So, any thoughts or comments on how we would balance honesty with the people that we're serving, and be able to understand concepts of what they're going through in terms of desire, intent, and capability for risk of harm to self and risk of harm to others? And how do you balance that versus so that you can create that engagement when you find out about it versus it being, oh, here's an intervention, we're going to have a coercive thing going on?
So part of it is being clear about what are the rules of the road up front when you can, or explaining them as you go along. And part of that is being comfortable with risk. And that takes a little bit of experience, and that takes a lot of sort of leadership support. A lot of frontline folks may not feel comfortable with this if their bosses aren't comfortable with it, right? We shouldn't be hospitalizing. We shouldn't be doing involuntary emergency interventions unless we really think that we have to do it for life safety. And we need to appreciate that people can be really homicidal, having a lot of those thoughts, can have a lot of homicidal or suicidal thoughts and not have current intent or current risk, right? There's this old line from Nietzsche that the thought of suicide gets one through many a dark night. And we've got to meet people where they're at, right? You might be talking to someone you know fairly well, and you say, gosh, I know some people use that like on a scale of 1 to 10, how suicidal are you? And they're like, well, I'm like a 7 out of 10 suicidal today. And you're like, that's fantastic. Like, what changed? You were a 9 out of 10 yesterday, and you're usually never below an 8. Like, what's working for you? Like, this might be a huge win for this person. And throwing police at them to involuntarily hospitalize them ain't going to help them out. It ain't going to reduce their stressors or their risks. It isn't going to give them the long-term recovery pathway that they need, right? And then someone else who baseline might be completely non-suicidal, like, well, I'm like a 3 or 4 out of 10, and like, whoa, that's different. What's going on? We've got to understand that. And maybe we need to think about, a higher level care. Maybe we don't, but we've got to do it based on the acute risk, and mere thoughts alone shouldn't necessarily do it unless there's some other risk factors pointing us in that direction. People have homicidal fantasies. You interview college students, something like, 3/4 or more of them have had fairly specific homicidal thoughts. It's not just like, oh, I could just kill someone. No, it's like Professor Plum in the library with a wrench because they grew it on a curve. Like, they thought out like how, when, and why. And thankfully, most college students not very violent, right? I saw a data set that most employees who've had a job for longer than a year have had violent or homicidal thoughts towards their boss. I got like almost 200 people reporting up to me, at least, right? I don't love that data point, but it's a real data point. Like, you're allowed to be pissed off and angry. And our job in crisis is to give people a safe space to say, I'm pissed off, and to help someone work through that. And to do that, you got to be comfortable with risk. You got to be comfortable with some of that tough emotion that people have. You got to turn into the skid, is what John Birchnell used to say in The Samaritans.
I love that quote. You got to be able to turn it to the skid. And I think that's one of the challenges is that the comfort level to be able to engage into the risk, it takes a comfort level to be able to talk about those things. Do you have any examples that you could share with us where uh, moving beyond that prediction or risk liability mode and really leaning into the engagement made a difference in preventing harm to others, for example? Any specific ones that you could share with us?
Yeah, you know, it's um and by the way, the data is really clear. We're not very good at prediction, especially over longer periods of time, especially with higher risk events. Um, and it's tricky, 'cause, you know, I'm a psychiatrist and I have the power to yoink away people's civil rights and put them in a hospital against their will because the legislators and the courts believe for various and sundry reasons that I am not bad at prediction, right? I'm not hospitalizing for the prior behavior. That if I'm doing an involuntary commitment, I'm doing it because of risk of imminent future behavior. Um, but we've got to let go of the the hope, the ambition, but frankly, sometimes the fantasy that a short-term hospitalization is going to do that much in and of itself, right? Um, I wish psychiatry, I wish what we did in crisis work, like, you know, one touch, you know, wham, you know, great, you know, a total fix. But usually when someone's in enough of a crisis that they need, you know, people like who are on the call today, they got a lot going on and we got to build that relationship. And can I give you examples? I can give you more examples than I can count of this and people that I've worked with off and on in different crisis settings through the years. You know, sometimes crisis it's like a quick touch one and done kind of thing. Sometimes we build up really robust relationships with the folks in our community, sometimes more than any other provider, any other treatment team that's out there. And sometimes that's a good thing, sometimes it's not such a good thing. But boy, as a medical director, as a crisis worker, like I want to make sure that if we are that regular touch, it's a good thing for them.
Yeah, that's so important. Justin in the chat base, strong peer leader from Nashville said people with lived experience are even more hesitant to share honest feeling because of prior experience of being institutionalized. And
Yeah.
that was really reflected in that study that we just had. I like to think if going forward, if that's where we need to be, and we need to think about how do we support all of our teams being more comfortable with engaging with risk, and still understanding some of the elements that go along with risk in harm to self or harm to others. I think one of the things I see just as a comment I'll make it, and you can reflect on that, and then I'm going to ask you, what would you do to change the system if you could do things? But the comment I would make is that oftentimes in my work, I see our staff, if they are using types of checklists to figure out certain things, the intervention is not to, oftentimes I see the structure of the interventions is not being engagement or conversation or collaborative safety planning. It's, do you go to the hospital or not? Or do you get to, are we going to get you? And is that what's going to happen versus we got you and surround, support, and help? So any thoughts on that? And then we'll get into system change discussions.
Yeah, right. I'd rather someone walk away from a clinical encounter where that crisis professional or that crisis peer worked really hard to create a meaningful relationship, right? We know that meaningful connections are powerfully protective against suicide and against violence. And so whatever we can do to sort of craft and nurture that meaningful relationship, understanding boundaries and privacy and all the other stuff, we want to do that, right? We know there's good research on this. Why don't people disclose the suicidal thoughts? Well, a big one is there's shame. Like, I don't want to get hospitalized. There's fear of, I don't want you to think of me as a person who has these types of thoughts. But also, impulsivity is a pretty big factor in suicide. And that's something we know that if we go back and look at people who made fairly dangerous but ultimately non-lethal suicidal behaviors who'd recently denied suicidality to someone and were able to go back and interview them, one of the things they say most of the time is, yeah, it was actually really impulsive, right? There was something from the end of that phone call, the end of that mobile visit, the time I walked out of the hospital until I made that really dangerous behavior that changed everything. And that's an important thing to remember, right?
Yeah.
So what do we do, right? Well, one of the nice convenient things is most of the biggest risk factors for violence are also some of our biggest risk factors for suicide, right? Acute stressors, substance use, access to lethal means, and a country where we have easy access to firearms and not so easy access to good caring behavioral health professionals. That gap can be problematic, right? Um, but the acute stressors, relationships, especially recent humiliating relationships, a breakup, not just dismissed from work, but walked out by security, like those embarrassing things. And when you lose work, everything else falls apart. Your health coverage, money, housing, again, your social status, recent violent victimization, but also prior stressors, right? These are all big risk factors for both. We got to look at both of them. And of course, substance use, not necessarily substance use disorder, right? It's not like Jack has alcohol use disorder, but today Jack's had a couple, knocked down a couple, right? The acute intoxication is what increases the risk for suicide, for violence, rather than that underlying classification of a disorder. So we got to look in the moment with that person. How do we relate to them, and how do we bridge small gaps, right? I don't want a safety plan that's going to work for the next 12 months. I want a safety plan that's going to work until the next phone call, the next mobile visit, till the next outpatient appointment. And if that outpatient appointment is Thursday afternoon, great. If it's November, we got problems, right?
The dynamics and the dynamic nature of safety and risk and safety planning and using that safety plan so that it's authentic and connected to you. I mean, that's another relationship and leaning into the engagement of the risk that's so important. So if you could change one thing in our system to help us do a better job of these elements, what things come to mind?
Yeah. So one of the things I've always said is, like, somewhere out there, and maybe some of you are lucky enough to be that unicorn or to employ that unicorn, but there's someone who is like really good at filling in all the boxes in the damn spreadsheet and really good at being present and human in the moment with that person in crisis. In my experience, and certainly in my own brain and personality, like those are not things that go well together. But it's like a skill set that we need in our rising generation of crisis professionals. Or maybe we need better tools to help us think through some of those things in real time, right? Everyone sort of waves the banner of, AI is going to be this great helpful tool. And wouldn't it be nice, especially for our phone clinicians, for something to be able to listen in and fill in all the boxes in the spreadsheet so that we can have good measurement and data collection and tell our stakeholders what they're getting for their money, and to tell our quality teams where we need to improve and how we need to adjust, while letting that clinician focus on being present and human in the moment. And I feel like the technology is maybe getting better. I don't think it's ready for prime time. And there's also this part of me that always remembers that it's the same technology that I keep wanting to text my friends about. Well, ducks. We'll just leave it at that.
So it's almost like it's two C's. Like we want to minimize the checklist, maybe be able to do it easier, because you do want to understand some of the elements of risk and understand concepts of intent versus just desire and those types of things. However, the other C is conversation. Like, how can you accomplish that? And it is a unicorn thing. And how do we continue to evolve the system so that it's easier for everyone that does this work to be able to do it in a conversation? And it's just
nurturing commitment to be willing to lean in and engage with people about really sensitive stuff and having tough conversations and not brushing on it like, hey, you know what? It's really important for me to understand all about your suicidal thoughts, because my biggest goal is that I want you to be safe. But for me to do that, I've got to understand you. I need your help to have that conversation better. And please know, the last thing I want to do is something involuntary. But the one thing I want to do less than that is listen to this phone line go silent, right? At the end of the day, we work in suicide prevention, not suicide bystanding. And that's an important ethical rule that we have to come back to. But boy, we've got to be thoughtful about being comfortable pushing, maybe not all the way to that line, but as close as we comfortably can. And Is it courage? Is it comfort? I don't know, right? It's a scary place to be out on that tightrope with someone in crisis. But we've got to support our staff in having those tough conversations with people in need.
I just can't tell you how much I appreciate your time and being able to talk through this. It is a reality that we've got some gaps in the system that we need to get it better. However, it is possible to do, and I so appreciate that you've been able to share some of the details and thoughts about ways we could think about that and continue to think about violence and harm to others as an important part of our whole crisis spectrum and being able to continue to get better at that with what we do. So thank you so much.
Thank you for having me.
I want to take time out to thank both of you as well, Dr. Rozel. Thank you, Chuck. Absolutely wonderful amount of information in such a short period of time, but you can see in the comments in the chat box a lot of really supportive components. I did want to point out, I saw Representative Tina Orwell's note in there where she talked about supporting legislation so that there would be mandatory suicide assessment referral training for medical staff. Just thought that was a wonderful way of just kind of acknowledging the need there. So I want to thank you both. And if you'll hang in, we are going to go to our notable roundtable live. And we're going to start off with my friend, Tanja Miles, who's an author, veteran, CEO of Set Free Indeed Ministry. And it's always wonderful to hear from you, Tanja. Your comments on the latest speakers.
Oh, wow. Well, I have so many different notes. I'm still, and if I'm laughing, you know how your mom say, I'm trying to laugh to keep from crying, because I'm still stuck on when Dr. Jack said, if you're doing a safety plan for a year and not in the moment. I mean, for real, we still having those conversations. I mean, it's almost like if someone's hungry and they're saying, I'm hungry, and it's like, okay, here's a meal plan for the next year. No, I just need one for today. And so I was like, wow, it's those kind of things we have to be mindful of. A safety plan in a moment. I just wrote down some other things as he was talking, as we're talking about a checklist, and that comes with training. Well, it's okay to have that checklist and that training as a whole, but we have to engage for the one, meaning that all the checklists, all the training that we get is still about that one person that we're engaging in at that time. And to really do that active listening to see if it's something that, if it's, that we need to go next level with. I also took a note, we know there are going to be risk when it comes to crisis. We know that, but I also believe that when we go in knowing, we go in not in fear, but we go in faith of the training and the humanity that we all have when we're engaging that individual. And then the last thing is, again, active listening. It's okay to have that basic, that foundation, that checklist, but at the end of the day, just really active listening, to that person that's sitting in front of us, to take that extra time to just really, dive in. And, when it comes to harm and risk to themselves or others, I'm glad we're having these conversations. And again, if we're still having a conversation about, a safety plan, when someone's in front of us and they're in a crisis and we give them a safety plan for a year, not in a moment, these crisis jams are needed like never before.
I mean, Tanja, as always, just so much in so little time. Thank you so much for your comments. I thank you so much for that input. You can see from the chat box, if you have a chance, your love and support that's being pushed in your direction. Just know that we look forward to hearing more from you. Stay with us because this topic is something that still has a long way to go. So we're going to be working on it throughout. And thank you. I also want to go into our next person, Attorney Skip Simpson, and who's in the lead office, nationally recognized expertise in suicide, focused on psychiatric malpractice. Mr. Simpson, just your comments, sir, on what you heard today.
Well, everything I heard today was just outstanding. But one of the things that the reason why it's so outstanding is because when I end up suing someone because they've had a death by suicide, they so don't, they're not anywhere near where this conversation is. They don't really know anything about warning signs. They don't know anything about, or very little about how to assess for suicide, how to elicit suicidal thinking. And I'll ask them, you know, what did you do to try to figure out what your client was thinking about suicide? And they never have really a good answer. You know, well, when was the last time you talked to them about suicide? You know, I sort of use a chronological approach that Sean Shea uses, uh, uh, which really gets me into some good questions. Well, if you were talking to them about suicide, if you can remember when the last time it was that they talked to you about suicide, what did they say?
Mm-hmm.
Did they talk about any kind of a plan? Did they talk about a gun? If they did talk about a gun, did they have the gun actually in their hand? Did they cock the gun? Did they put it in their mouth? What was going on in their head at the time? What was it that caused them from pulling that trigger? You know, when you get into those kinds of details, it becomes clear that they didn't have a good conversation with their patient at the time to know whether they were suicidal or not. So when I hear what I'm hearing today, you know, this is the tip of the spear. Everyone here knows what they're talking about. They, you know, what you just said about a safety plan or for eating. You know, I don't want to plan for a year. I'm hungry right now. What can you give me right now? You take that kind of a concept and break it down into other areas. That's the kind of common sense thinking that you want. What did you do in this conversation or during the time you're with your patient to give them hope? And they, I don't, again, the people that I'm dealing with are people who have had suicides. And there's a reason why they had a suicide, because they had not connected with their patient. And it becomes clear when we look at a case, we really break it down really hard. I reject probably 98% of the cases that come across my desk. And a lot of it has to do with people really did do a good systematic suicide assessment. I could see that they did that. I could see that they had heart. I could see by heart, I mean that they were engaged and they were treating the patient like it was a family member. But they had the intelligence and the sense to use the right questions to help the family member. I use a lot of Paul Quinet's stuff with QPR. So I guess what my thoughts are of what I've heard so far is it's just outstanding. I wish everyone had the time to listen to people like you guys.
Well, I wish we had time to listen to more of what you have to say, because you are phenomenal in terms of your in-depth view of what is going on and the steps that are being taken. It sounds like a remarkable thing that you're doing, so please keep it up. And I want to personally thank you for being a part of this roundtable. I want to thank Tanja as well for being a part of the roundtable. It's so crucial that we get this feedback either for the speakers or just for the chat group, the folks that are out there that may be wondering those questions, and having them addressed in this kind of format is just outstanding. So thank you, Simpson. Thank you, Tanja. Look forward to further collaborations with you guys, but we thank you for being a part of the roundtable.
Thank you.
All right, we're going to move to the briefing room, where at this time we normally have SAMHSA update. It would have been Dr. Richard McKeon who would have been in the position today, and he was eager to come and was all set, but unfortunately due to the government shutdown, he's unable to be a part of the briefing from SAMHSA to us today. We wish them all the best. So we're going to move into the briefing room from NASHBID, And we have today with us from Nashville, our Chief of Staff, Megan Haupt. And Megan's going to give us an update on happenings with Nashville. So Megan.
All right. Thank you so much, Dr. Sims. And here I am again in the same episode. And I just so love the Crisis Jam. And I love partnering with you on it. And all of our partners, just absolutely fantastic. And so glad that it's making a difference. And the conversation today is phenomenal. Dr. Rozel and Dr. Chuck are just a very authentic, genuine conversation. They modeled the connection that's needed when you are talking with somebody that's at risk. So just thank you for that. So what I wanted to talk about today was the National Dialogues for Behavioral Health Conference, and that's taking place October 26th through October 29th in New Orleans, Louisiana, at the Renaissance Arts Hotel. It is the 66th annual conference of NDBH, and it is the oldest mental health conference in our country. And so we pick a theme each year and work on that theme, and the entire conference is developed around that theme. And this year's theme is Behavioral Health and a Changing Environment, Adapting and Thriving. Now, why that is important, obviously, our environment is changing. We want the most cutting edge. How do we look at things in the future as funding changes? So the other really cool part is there's a pre-conference on that Sunday, October 26th. It's from 9:30 to 12:30, and it is on cutting edge strategies and lessons learned in behavioral health, disaster planning and management. And really thrilled that Dr. John Draper, as well as Sherry Sinwelski from Dr. John Draper's with Behavioral Health Link. Sherry Sinwelski is with Dee Hirsch. There'll be other presenters as well, but just some really heavy hitters there. There'll be sessions on strategies to address policy and funding throughout the start of the conference. Kirsten Baronia will be presenting as part of that. They'll be building the future of the system of care, a blueprint for moving challenges to solutions, one on best practices in the changing landscape and the future of workforce. The key thing, it's not just about the topics, it's that there are in-depth presentations along with extended dialogue. If you look at this agenda, I don't know if you can see it, but we have almost 45 minutes to an hour of dialogue related to these topics. And it's not just question and answer, it's really exploring each topic. And it's just a really gem of a conference is how we like to describe it. So we hope that folks can attend. Here is the website if you are interested in registering. And it's also on the crisisjam.com website under events. So thank you so much.
Well, thank you, Megan. And maybe we can, before the close, post that website. I didn't see it up on the screen, but maybe post it in the chat box for those that maybe.
Yeah, it's in the chat box right now.
Okay, beautiful. There it is. Absolutely. Thank you so much. And
Thank
Megan, as always, thank you so much. And we're going to move ahead to Voices in Crisis Care. And we have with us today, and I hopefully will pronounce the name correctly, but he truly is a champion, Greg Deshari. If you are available, sir, if you'll come on board for our Voices in Crisis Care, we look forward to having you with us. Hey there.
Hey there. Thanks for having me.
Well, Greg,
Sorry,
before you get
calling
started,
in from the car.
I wanted to just check with you real quick to see if the last name was pronounced correctly, sir.
Deshari is how it's. I
Deshari?
think you were pretty close.
Well, I appreciate that. Well, please go ahead, sir.
Sure. So thanks for having me on. It's great great to see the Crisis Jam still going strong after so many years. I was on in the early days and periodically over the years. Also, thanks to David Covington and the whole RI team, Crisis Jam team, who've been such great champions with this. I got introduced to the world of crisis services via the Los Angeles Police Department back in 1995 when I had my first manic episode. Luckily, they were very nice and, brought me to Cedars-Sinai Hospital. And since that time, I've had well over 12 hospitalizations that also included escorts by the police officers. I've been very blessed that had lots of them, or pretty much all of them, were very kind and nice and probably had some type of CIT training. But even not, I was very blessed and lucky, I should say, that I didn't have any real adverse effects, even though I did things like kick out the bottom window of cop cars twice and wasn't very was quite unruly a lot of the times. But I am blessed to the petition process, which was touched on a little bit earlier. I've of all of those times, it's been where I've been petitioned. It's called a little bit different in the different states. But with my mental health disorder, my bipolar disorder, once I get to a certain point, I'm not one to say, hey, let me go check myself into the hospital and get some help. The only way I'm going is if police come and say, hey, put your hands behind your back. We're taking you somewhere. In the times that happens, obviously, I'm not very happy with it and don't see it as a very enjoyable or desirable experience. However, after the fact, I can recognize pretty much all those times it was really often a life-saving tool that was used to get me help. When I get out there in these episodes, I can get very crazy, for lack of a better words. Definitely can be a danger to myself, and as much as I don't like to admit it, could be in danger of others. I haven't done that at this point, but some of my disordered thinking really could go there, and kind of violent in my thinking and stuff like that. I have worked in the mental health field for about 20 years. I don't currently now. I was in very early days in Arizona, actually did some videoing with David at the crisis center there. I've had a variety of experiences in these types of facilities that were better than others. Early on in Arizona, and some of these places that you go to, and it really just exacerbates my symptoms. So I'd be kind of not well, but get in these facilities, and it's just like it just escalates. My symptoms just really escalate. I get more psychotic. I guess maybe some of the stressors of being there. A lot of these places are very dirty. They're not like really just very dirty, not great experiences where you want to put someone who's not always doing well. So and then and over the years, I've also worked in crisis. My work at Magellan, as far as leading up some of the suicide preventions works there. I've done a couple of films, one called Suicide: The Ripple Effect, one called My Ascension, that focused on suicide prevention and crisis. And so with those experiences, I've been blessed to work with a lot of the leading experts and advocates in the space, and have gotten to see a lot of the real benefits for myself, but also for others around crisis services.
Well, I'll tell you, Greg, you're getting a lot of wonderful comments in the chat. I did want to ask you a quick question. I understand that you've been a leader in a program across the country called My Life. Could you talk a little bit on that?
Sure. That was a program, actually, when I worked with David at Magellan. I'd started a little bit before then, but it was basically a youth leadership program geared towards young people who have experience with mental health, substance use, juvenile justice issues, and basically giving them an opportunity to use their voices to give back, to help one another, to advocate on a legislative level, also with healthcare providers. So I started that in Arizona in 2009, and then had replicated that around the country in 6 different states. So.
Well, you have some wonderful, as I mentioned, comments thanking you for sharing and talking about what we must do to hold hospitals to higher standards and other types of treatment strategies. I did have a question from one of our peer lived experience individuals. Justin had placed in the chat box talking about difficulty sometimes for those who have suicidal ideations to talk to professionals about it. Has that been your experience? And if so, has there been something that you've done to kind of help with that process?
Yeah, I mean, I think it's difficult for anybody to talk about who's experiencing those issues, and it's difficult for people to listen to and have those, issues. In my previous film, My Ascension, Dr. Frank Campbell speaks of that as far as like how many professionals who work in the field are so nervous to talk about these issues or even to broach the question. They're worried they're going to do something wrong. I didn't even know the whole thing of being sued, which is a whole another development, on it. So I think the more that we can really train people with the kind of knowledge that you guys have, and so that people are feeling comfortable about it. I mean, there is also the issue of people being reluctant to share, particularly about the suicidal thoughts, because they're worried about they're going to be, thrown in the hospital, or maybe there's a girl also in my last film, Karen, who was 15 and she was hospitalized for suicidal thoughts and kind of learned the game, which we learn when we have mental health issues, because nobody wants to be in the hospital at the time. So we learn like, hey, I don't want to say this because they're going to keep me in the hospital longer. I don't want to say this. They're going to, make me go to the hospital, or can say this and then they'll let me out of the hospital. So it's definitely a tricky situation, because someone like, myself and a lot of people can benefit from being in the hospital, but also by going into the hospital, it can help or make people more silent about what they're dealing with because they don't want to go in and have that experience at the hospital.
Wow. Well, understood, Greg. And again, thank you so much for this talk, and thank you for giving your story. And you can tell it was such needed story. So thank you for sharing it with us. Thank you for all that you do, because in this realm it is so needed, and it's wonderful to have these kind of conversations. And keep up the good work, sir. So thank you.
Hey, thank you very much. I
today.
appreciate the opportunity.
Righty. At this point, I'm going to pass it over to Kristen Ellis, who's going to carry us through to the end. Kristen?
Thanks so much, Brian. What a great episode today. Huge thanks to Dr. Jack Rozel and Dr. Chuck Browning for leading us through such an important conversation. If you haven't checked out the chat, please do. And thank you so much to our headliner sponsor. If you missed it last week, it's AHP. We are gathering a diverse group of sponsors across the behavioral health industry. And in the coming weeks, we'll be announcing a few more of our partners. But if you'd like to help keep the Jam Stage lit every single week, please reach out and join us as a sponsor. Next week, Dr. John Torres is going to talk about mental health apps and what they mean for 988. And then in 2 weeks, we are going to bring you big feelings in the real world. I'm really excited about this because if we're actually going to accept folks who are under the influence, presenting in high acuity, or having big feelings, as this title indicates, then there deserves to be safety, dignity, and respect for all, including the guests and those that are serving them. This conversation is going to feature Kim Sanders, Matthew Holtzclaw, and moderated by Dr. Chuck Browning, who moderated today. And in 3 weeks, we are going to focus on from screening to safety. Dr. Kelly Posner Gerstenhaber, I hope I said that correct, Gerstenhaber, will guide us through using the Columbia protocols in crisis care that are used across so many of our services. We are kind of excited for all of what's to come in season 6. It's going to be our most dynamic yet, if you haven't noticed so far. Be sure to check out crisisjam.com, get your swag at crisisjam.shop. And thanks for watching. We're going to want you to tune in, log on, join the movement, and we will see you next week.